Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for oromaxillofacial services. There are some changes you'll need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. We'll drill down to the essentials. So let's get started. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site. A little more on each of these. Differentiate in your notes, for example, whether or not a condition is acute or chronic, aggressive or plaque-induced whenever appropriate. For example, document chronic gingivitis instead of gingivitis. Use due to or secondary to indicate cause and effect, and to record all conditions the patient may have, such as osteonecrosis of jaw due to therapeutic radiation. Be specific about documenting aspects of the disease process, such as edentulosum class 2. Precisely designate anatomical sites, such as fracture of subcondylar process of mandible. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases that have new documentation requirements under ICD-10. In ICD-10, there is a feature called laterality for right, left, and bilateral, which is found in many diagnoses and procedure codes involving paired organs or those codes specific to one side of the body versus the other. For example, inguinal hernias. ICD-9 had a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes, which you have probably heard so much about. Since you usually include this information in your patient care notes when applicable, additional documentation will typically not be needed. So FYI, if you happen to omit laterality when needed, it may result in a query. Suffice it to say, laterality is included when appropriate for some conditions you may treat. So do a quick double check of your notes to be sure you included it before signing off. We'll try not to belabor this point in the upcoming slides. In ICD-9, cellulitis and acute lymphangitis shared the same code. ICD-10 provides separate codes for each condition. You should also be aware that when a patient has both a cellulitis and acute lymphangitis, coding convention directs that only the code for cellulitis is assigned. Lastly, you should document the infecting organism if known or suspected. What's new with the codes for dental caries in ICD-10 is that they have undergone some revision and are now combination codes. Dental caries is first categorized as being on the pit and fissure surface of the tooth or the smooth surface of the tooth. It is then further specified by the depth of disease progression into the tooth, either being limited to the enamel of the tooth, penetrating into the dentin, or penetrating into the pulp. So the next time you are documenting a diagnosis of dental caries, please indicate the tooth surface and the depth of disease progression in order to avoid an unspecified dental caries code. Data on dental caries is collected as part of the National Oral Health Surveillance System, which is a subcomponent of the National Public Health Surveillance System. Oral public health initiatives can be designed appropriately when the data collected is accurate and specific. ICD-10 brings less specificity to the codes for gingival recession than ICD-9 did. In ICD-9, there were 6 codes for recession. In ICD-10, there is 1. There are no new ICD-10 documentation requirements for gingivitis. You should continue to indicate if acute or chronic and whether it is plaque-induced or not. The same goes for periodontitis. There are no new ICD-10 documentation requirements here either. Continue to specify if the periodontal disease is acute, aggressive, or chronic, and if the disease is localized or generalized. ICD-9 required 2 codes to identify acquired tooth loss, one for the class of edentulation and the other for the cause. What's nice is that ICD-10 provides combination codes that capture both the class of edentulation as well as the cause. So if you make sure to document in your notes whether the loss of teeth is complete or partial, the class of edentulation, class 1 through 4, and the cause, such as trauma, dental caries, periodontal disease, a code that captures all of these elements will be assigned. ICD-10 continues to distinguish between open and closed fractures of the jaw, as was the case in ICD-9. Unique codes are still provided for the specific part of the mandible fractured, for example, condylar or subcondylar process. So be as precise as possible when recording your diagnosis of fracture. ICD-9 did not provide a specific code for a Le Fort fracture. Instead, a Le Fort fracture was classified to a code for a fracture of the maxilla. The good news is that ICD-10 does by providing codes for Le Fort 1, 2, and 3 fractures. Traumatic care codes have a 7th character that indicates whether the encounter for fracture care is the initial encounter of care or subsequent encounter of care for a fracture that is routine healing, has delayed healing, or non-union, or an encounter to address fracture sequela. For example, if you are seeing a patient in the office for follow-up of a Le Fort 2 fracture that is routinely healing, the 7th character of D would be added to the code. Your notes usually indicate the nature of the encounter, that is, initial, subsequent, or sequela, which will provide the information needed to select the correct 7th character. The only thing new with dentofacial anomalies is that the codes have moved from the chapter on diseases of the digestive system to the chapter for disease of the musculoskeletal system and connective tissue. This information will be useful for your coding and billing staff to be aware of. The conditions in this section include temporomandibular joint disorders and anomalies of jaw size, dental arch, tooth position, and dental alveolus. Like ICD-9, ICD-10 classifies these disorders the same, so continue to be as specific in your documentation of these conditions as you are now, which will ensure correct ICD-10 code assignment. There's not much new with trigeminal nerve disorders. ICD-10 continues to classify trigeminal neuralgia as simply neuralgia or as post-herpetic. The only new addition in this area pertains to traumatic injury of the trigeminal nerve, in that a 7th character is assigned to the code to indicate if the encounter was the initial visit, subsequent visit, or for treatment of sequela. There are no new ICD-10 documentation requirements for the diagnoses of osteomyelitis and osteonecrosis of the jaw. Continue to document in your notes if osteonecrosis is due to medication or radiation, so the respective codes that reflect these etiologies can be assigned. It's interesting to note that the code for osteomyelitis of the jaw is classified to code M27.2 for inflammatory conditions of the jaw, which was the case in ICD-9 as well. Osteomyelitis of most other bones is classified to category M86, which is entitled osteomyelitis. As I mentioned earlier, ICD-10 has greater specificity for anatomical site. Be sure your documentation is as specific as possible when identifying the anatomical location of a neoplasm, such as neoplasm of the anterior 2/3 of the tongue, the soft palate, or the posterior wall of the oropharynx. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a malignancy would be patient with history of cancer of the anterior 2/3 of the tongue. Patient underwent partial glossectomy 1 year ago with no evidence of recurrence. This documentation clearly identifies the primary and secondary sites and states the primary site is no longer present, all of which are factors considered in code assignment. It is perfectly acceptable to state primary site unknown or to state a diagnosis as possible or probable. If you treat patients with sleep-disordered breathing, such as obstructive sleep apnea or snoring, you may be interested to know the ICD-10 terminology describing obstructive sleep apnea remains essentially unchanged from ICD-9. Please take a look at the ICD-9 code and its ICD-10 counterpart on the screen. You may also be interested to know that ICD-10 provides a specific code for snoring where ICD-9 did not. This will provide insurance companies with better information when processing claims for any snoring-related appliances you provide to your patients. The look and feel for codes describing diabetes have changed, but the level of detail describing the disease remains mostly the same. Therefore, your documentation doesn't need to change as long as you are currently documenting the type of diabetes as type 1 or type 2, and any associated complications, for example, diabetic periodontal disease or diabetes with other oral complication. The good news is that ICD-10 uses single combination codes to describe the disease. ICD-9 usually required multiple codes. Take, for example, the diagnosis of type 2 diabetes with diabetic periodontal disease. This diagnosis required 2 codes in ICD-9, but in ICD-10, 1 code reports everything. As you are aware, tobacco use is a risk factor for oral diseases. Oral health professionals are often the first people to screen and identify these diseases, so it's important to spend a few minutes reviewing what's new in ICD-10 regarding tobacco use, abuse, and dependence. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, Further specificity is provided in ICD-10 for the type of tobacco product dependence. These are cigarettes, chewing tobacco, or other, for example, cigars. So this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. In addition to several other chronic diseases, tobacco use is a primary cause of many oral diseases and adverse oral conditions. The World Health Organization has strengthened the work for effective control of tobacco use. Oral health professionals and dental associations worldwide should consider this platform for their future work for tobacco prevention, since in several countries they play an important role in communication with patients and communities. In addition to tobacco, alcohol is also a risk factor for disease of the oral cavity. So let's talk about what's new in ICD-10 for alcohol use, abuse, and dependence. ICD-10 provides combination codes to report the use, abuse, or dependence of alcohol along with any associated manifestations such as dementia or psychotic disorders. There are many more codes available in ICD-10 to identify specific manifestations associated with substance abuse and dependence. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, with no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient was seen in the office today for follow-up of dental abscess. Patient informed me that she discontinued the penicillin after 3 days because the tooth felt better and the antibiotic was causing GI upset. ICD-10 requires more detailed descriptions in your documentation of anatomical site, laterality, and aspects of a disease, injury, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patient's severity of illness and risk of mortality and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Thanks for joining me. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your health information management department is a valuable resource as well. Have a great day.